Basal cell carcinoma, understanding the most common skin cancer. Basal cell carcinoma is the most frequently diagnosed skin cancer worldwide. Though it grows slowly and rarely spreads, early detection and treatment are essential for optimal outcomes. What is basal cell carcinoma? Basal cell carcinoma represents the most prevalent malignant skin condition encountered in clinical dermatology worldwide. This disease arises from the basal layer of the epidermis, which contains specialized cells that normally function to replace outer skin cells as they naturally shed. When these basal cells undergo malignant transformation, they can develop into invasive lesions that progressively expand into surrounding tissue. Despite being classified as a carcinoma, basal cell cancer demonstrates relatively benign biological behavior compared to other skin malignancies, with a very low propensity for distant metastasis or fatal outcomes when appropriately managed. Clinical presentation and diagnostic features. The clinical appearance of basal cell carcinoma varies considerably depending on the histological subtype and individual patient characteristics. Many patients initially notice a painless bump or nodule on sun-exposed skin that either remains stable or gradually enlarges over weeks to months. The lesion frequently displays distinctive surface features, including a pearly or translucent quality with a characteristic shiny appearance. Superficial blood vessels, or telangiectasias, often become visible traversing the surface of the lesion, creating a network-like pattern that experienced clinicians find diagnostically helpful. Key points: nodular lesions appearing as firm, flesh-colored or slightly pigmented bumps with visible blood vessels. Ulcerated variants that develop central erosion or open wounds, historically termed rodent ulcers due to their appearance. Superficial forms manifesting as scaly patches or plaques that may resemble eczema or psoriasis. Pigmented subtypes that contain melanin and may be confused with melanoma on initial inspection. Risk factors and epidemiological considerations. Ultraviolet radiation exposure remains the predominant environmental risk factor for basal cell carcinoma development. Cumulative sun exposure over the lifetime significantly correlates with disease incidence, making this malignancy predominantly a condition of sun-exposed anatomical sites such as the face, ears, scalp, and upper trunk. Individuals with fair skin phenotypes and reduced melanin production face substantially elevated risks compared to those with darker complexions. Additionally, occupational exposure to carcinogens, immunosuppression from medications or systemic disease, genetic predisposition syndromes such as nevoid basal cell carcinoma syndrome, and advancing age all contribute to increased disease susceptibility. Prior radiation therapy, chronic inflammatory skin conditions, and exposure to arsenic or other chemical carcinogens represent additional identified risk factors in selected populations. Pathological classification and subtypes. Histopathological examination remains the gold standard for definitive diagnosis and classification of basal cell carcinoma. The nodular subtype, the most commonly encountered variant, presents as discrete nests and islands of basaloid cells within the dermis with peripheral palisading of nuclei. Superficial basal cell carcinoma features buds of neoplastic cells arising from the epidermis that extend into the superficial dermis, often presenting clinically as scaly patches that can be challenging to distinguish from benign inflammatory dermatoses. Infiltrative and morpheoform variants display angulated nests and strands of tumor cells that interdigitate with surrounding stroma, often with associated desmoplasia, contributing to their more aggressive biological behavior and higher recurrence rates following treatment. Diagnostic approach and clinical evaluation. Accurate diagnosis of basal cell carcinoma requires clinicopathological correlation integrating clinical observations with histological findings. The dermoscopic examination has emerged as a valuable non-invasive diagnostic tool, allowing identification of specific architectural patterns including arborization, multiple blue-gray globules, leaf-like areas, and short radial streaks that enhance diagnostic accuracy. When clinical suspicion exists, tissue biopsy provides definitive diagnosis and permits histological subtyping, which carries important implications for treatment selection and prognostic assessment. Mohs micrographic surgery, while primarily a therapeutic modality, simultaneously provides real-time histopathological examination during tumor removal, allowing margin assessment with microscopic precision. Treatment options and therapeutic strategies. Multiple evidence-based treatment modalities exist for managing basal cell carcinoma, with selection depending on tumor characteristics, anatomical location, patient age and comorbidities, and cosmetic considerations. Conventional surgical excision with predetermined margins remains widely practiced and effective, though margin requirements vary based on tumor size, location, and subtype. Mohs micrographic surgery offers superior recurrence rates, particularly for high-risk lesions, those in cosmetically or functionally sensitive locations, or tumors with aggressive histological features. Electrodesiccation and curettage provides an effective alternative for small, low-risk lesions on non-critical sites, employing mechanical removal followed by cauterization. Cryotherapy utilizing liquid nitrogen delivers excellent cure rates for selected superficial lesions, though it produces less optimal cosmetic outcomes for larger or deeper tumors. Key points: topical imiquimod cream, an immune-modulating agent that stimulates local anti-tumor immune responses, suitable for superficial lesions particularly on trunk and extremities. Topical 5-fluorouracil, a pyrimidine antimetabolite applied to superficial basal cell carcinomas, though cosmetic outcomes may be suboptimal. Radiotherapy for patients unable to tolerate surgical intervention or with advanced local disease, delivering fractionated external beam radiation. Photodynamic therapy combining photosensitizing agents with visible light activation, particularly effective for superficial variants. Prognostic factors and recurrence risk. Although basal cell carcinoma typically pursues an indolent course with excellent long-term survival rates exceeding 95%, certain variables predict higher recurrence risk and warrant more aggressive therapeutic approaches. Tumor size exceeding 2 cm, infiltrative or morpheoform histological subtypes, perineural invasion, and inadequately excised lesions all correlate with increased recurrence likelihood. Location on the face, particularly in the H-zone encompassing areas of significant anatomical complexity, predicts higher recurrence rates due to technical difficulty in achieving complete tumor removal. Patient factors including immunosuppression and genetic predisposition syndromes elevate recurrence risk substantially. Appropriate histological examination of surgical margins and selection of treatment modalities with documented efficacy for high-risk lesions significantly reduce recurrence and improve long-term outcomes. Prevention and early detection strategies. Primary prevention through ultraviolet radiation avoidance remains the most effective strategy for reducing basal cell carcinoma incidence. Consistent application of broad-spectrum sunscreen with appropriate sun protection factor, protective clothing including hats and long sleeves, and behavioral modifications such as limiting sun exposure during peak ultraviolet hours all substantially reduce disease risk. Secondary prevention through regular skin self-examination and periodic professional dermatological screening enables early detection when lesions remain small and treatment can be simplified. Patients with prior basal cell carcinoma require enhanced surveillance, as they face substantially elevated risk for developing additional lesions. Educational initiatives targeting sun-safe practices from childhood onward represent important public health interventions, particularly in geographic regions with intense sun exposure and populations with fair skin phenotypes. Complications and long-term outcomes. While basal cell carcinoma rarely metastasizes to distant organs, local tissue destruction from progressive disease can produce significant functional and cosmetic morbidity if left untreated or inadequately managed. Lesions on the face may progressively invade underlying structures, including cartilage of the ear or nose, eventually compromising function and creating extensive tissue defects requiring complex reconstructive surgery. Tumors in periocular locations risk extension into orbital structures or eyelid structures with consequent visual impairment. Very advanced locally invasive disease can occasionally demonstrate regional lymph node involvement, though systemic metastasis remains extraordinarily uncommon. Long-term cosmetic outcomes depend substantially on treatment selection and technical execution, with Mohs surgery generally producing superior aesthetic results compared to traditional excision or destructive modalities. Psychological impacts including anxiety and diminished quality of life, though frequently underappreciated, deserve consideration in comprehensive patient care. Special populations and clinical considerations. Immunocompromised patients, including those with human immunodeficiency virus infection, solid organ transplant recipients, or individuals receiving chronic immunosuppressive medications, experience dramatically elevated basal cell carcinoma incidence and frequently develop multiple lesions requiring sequential management. These populations often exhibit more aggressive tumor behavior and higher recurrence rates, necessitating closer surveillance and consideration of more definitive treatment modalities. Patients with nevoid basal cell carcinoma syndrome, an autosomal dominant condition caused by PTCH1 gene mutations, develop hundreds to thousands of basal cell carcinomas during their lifetime, requiring comprehensive dermatological management and psychological support. Elderly patients with significant comorbidities may benefit from less invasive treatment options, though functional status and life expectancy should guide therapeutic decision-making. Pregnant patients can safely defer non-urgent basal cell carcinoma treatment, though established lesions require monitoring to prevent progression and ensure timely management postpartum. Thank you for watching. For the full article, visit MedMind AI at medmind.pro. Like and subscribe for more evidence-based medical content.